friends, Pradeep Pindyala, Professor of Anesthesiology. Today I am going to talk something about very important topic for the point of view of Viva. You have these cases during the Viva. Invariably, the students face a case that is called fracture forearm. And I'm sure you know that Colles fracture is the most common fracture of the forearm. And why it happens? Because of the fall on an outstretched hand. The dinner fork deformity, you can never forget what you have learned during MBBS. And the distal radius is broken, and that fragment would be pointing upwards and backwards. That is the normal picture which you see, the typical dinner fork deformity of the Colles fracture. Now, for giving anesthesia for such cases, you have to give peripheral nerve block. So, peripheral nerve block can be given either with the nerve stimulator or using USG. Okay, and other option you have is Bayer's block. So, first ultrasonography and peripheral nerve block, I'll initially tell you about it, and later I will also touch upon Bayer's block, IVRA, intravenous regional anesthesia technique for giving anesthesia regionally for fracture forearm. That's a must. You have to know. There is no second thought. I'm sure you know peripheral nerves are terminal branches of the nerve roots arising from the dorsal ganglion of the spinal cord. No doubts? Okay. The peripheral nerve system has motor, sensory and autonomic components. They arise from the dorsal ganglion of the spinal cord. And what about brachial plexus? I'm sure you know the anterior division of the C5 to T1 nerve roots form the brachial plexus. There should not be second thoughts about. The roots normally pass dorsal to the vertebral artery through the intervertebral foramina. Now, at the first rib, what happens? Three trunks, superior, medial and inferior trunks, are descending. Okay, at the level of the first rib. And what happens at this thing? The anterior and posterior branch would be bifurcating at the level of the supraclavicular level. Okay, and having crossed the first rib, normally they separate into posterior, lateral and medial cords. I'm sure you know all this, and when you give a block, you usually give 25 to 30 ml of the drug combined with local anesthetic. Solution 0.5% bupivacaine and 2% of lignocaine with epinephrine. Okay, that is used preferably for a surgery of 45 hours and which will be effective even post-operatively. The complications could be pneumothorax, which is very common, especially supraclavicular block, and there could be intravascular injection of the local anesthetic causing local anesthetic toxicity, or it could be incomplete or partial block. So you should know about these things. And talking about IVRA, a German surgeon by name August Bayer discovered it in 1908. Okay, that's known as Bayer's block. What you do? Normally, the limb is exsanguinated using pressure bandage. Okay, that is known as Esmark's bandage. How it is wound? Around 2/3 overlap of the previous bandage. Okay, that's how you do. And what you inject normally 0.5 to 1%. Plain, preservative-free lignocaine. You don't use bupivacaine here in Bayer's block. Okay, nowadays they are using rocuronium, and what you are giving is lignocaine 0.5 to 1%. The dose is 3 milligram per kg body weight, and around 30 to 50 ml solution is slowly injected into the exsanguinated limb. Okay, this is what you have to do in IVRA or Bayer's block. about 20 to 30 minutes after the onset of anesthesia or when the patient complains of tourniquet pain. The distal cuff is inflated and the simultaneously proximal cuff is deflated. The distal cuff is inflated, simultaneously proximal cuff is deflated, so that to minimize the tourniquet pain, because the proximal cuff is not anesthetized, that area of the skin. So that is the cause of tourniquet pain. And even after the surgery, when the cuff is removed, everything is removed and the patient is relaxing, and God forbid you do passively or the patient himself does exercises, that can cause dangerous, because even after deflation there could be drug and that could cause severe toxicity. So you must not exercise inadvertently, okay, after deflation of the limb. Don't ever do that. And what are the contraindication of IVRA? Cellulitis, like any other thing, compound fracture, local infection, and of course sickle cell disease. And if the surgery is prolonged, if the surgeon says, the orthopedic surgeon says it is more than 1 hour or 2 hours, don't try IVRA. Okay, there are other methods, that is USG guided peripheral nerve block or nerve stimulator peripheral nerve block. Now, USG guided was discovered in 1978 by Lagrange. Okay, that was the first reported use of ultrasound for nerve blocks. High frequency normally is chosen around 12 to 14 megahertz. High resolution, linear probe. Other is curvaceous probe. Okay, and I'll tell you about that later. You normally use linear probe of high frequency, 12 to 14 megahertz, for giving peripheral nerve blocks. And it can be used even for anatomical localization of subarachnoid space, difficult IV location, central venous axis. All this can be used USG guided effort. Okay, the anesthetists are the boss now, using USG blocks and use of USG's ultrasound machines. Okay, now when you do, the probe is normally placed in interscalene space and it is moved in craniocaudal direction. And I'm sure you know, if it is in plane, the entire length of the needle is visible and nerve will be seen floating in the local anesthetic solution once you deliver the drug. Okay, where the puncture site is located cranially to the ultrasound probe. Normally you inject around 10 to 15 or sometimes 20 ml, not more than that, the drug when you are using USG guided block encircling the trunks. So during the Viva, you can be asked the difference between bias block and peripheral nerve block using nerve stimulator or USG guided block. And you can be asked about local anesthesia toxicity also. You should be prepared for that. And how do you manage the local anesthesia toxicity? You must know. What about supraclavicular block? I'm sure you know it is used for entire upper limb and provides good analgesia, and including muscular relaxation and sympathetic blockade. Well, as I had mentioned earlier, pneumothorax has to be looked for if you are giving supraclavicular brachial plexus block. Invariably, you can end up with pneumothorax. Please be careful. Where do you put the transducer? Normally at the midpoint of the clavicle, the probe line transverse to the clavicle. Okay, and how do you see? It's like, looks like bunch of grapes, the brachial plexus. Beautiful bunch of grapes. The bundle of hypoechoic round nodules. Okay, they normally lie posterior and superficial to the subclavian artery. You must know posterior and bit lateral and superficial to subclavian artery. Okay, biggest problem of supraclavicular block for that matter, the skin overlying the medial side of the proximal arm is never anesthetized. which is supplied normally by the intercostal-brachial nerve. This is invariably asked in Viva. Okay, what is the nerve that supplies the medial side of the proximal arm? That is intercostal-brachial nerve. T root is T2. Okay, nerve root is T2. Okay, and it is never anesthetized by any technique of brachial plexus block. This has to be achieved by separate subcutaneous infiltration distal to the axilla, which you have to give separate infiltration with the local anesthetic on the medial side of the axilla. Okay, distal to the axilla. That has to be separately be given. Whatever block you give, it will be spared that area. So that will cause pain during surgery. Another thing is axillary block. Axillary block is really good, but huge disadvantage that it cannot cover the tourniquet pain. Normally, the terminal branches of the brachial plexus are surrounded by which are the nerves? Musculocutaneous, median, radial, and ulnar nerve. That I'm sure. And you need to abduct the arm to 90 degree for doing the axillary block. The transducer is placed normally on the skin immediately distal to the point of insertion of pectoralis major. Okay, on the humerus. That is normally asked. And one thing which is left is infraclavicular block, brachial plexus block. And it has advantages. It has lesser incidence of phrenic nerve block, which can occur in supraclavicular block. And pneumothorax also is less compared to supraclavicular block. It gives anesthesia for distal, upper arm, elbow, forearm, and hand surgery for infraclavicular brachial plexus block. Here, the probe used is curved probe rather than the linear probe. That you must remember. Why curved probe? Because the brachial plexus is found little more depth than the usual. That is around 5 to 6 centimeters deeper to the skin around axillary artery. So that's why I use here curved probe rather than linear probe. The axillary artery is normally surrounded with 3 cords of the brachial plexus, which I'm sure you should be knowing: lateral, medial, and the posterior cord. Thanks for patient listening. Have a wonderful day. This is Colonel Pradeep signing off for today. Bye-bye.